Okay, so today we are having a discussion that's a very important and very timely conversation to have in the state of Massachusetts as our state legislature considers once again legalizing assisted suicide. For over a decade, probably closer to 15 years or so, Massachusetts Citizens for Life, in partnership with peers and allies across the state, a number of coalition partners, we have fought successfully to prevent the legalization of assisted suicide here in the Bay State. But once again, it is before our legislators on Beacon Hill. We're talking today with the executive director of Patients' Rights Action Fund, Matt Vallière, and he is going to talk a little bit about not only what's happening on Beacon Hill, but we're going to take a little bit of a step back and sort of start this conversation from the beginning, just to talk more about assisted suicide, because as this issue has made its way through our culture in the last 15 years, it's become more accepted than it once was. There's less of a shock factor to it, and particularly younger generations are finding nothing wrong with the concept of assisted suicide. So we're going to first step back and take a little bit of a look at the issue more broadly, and then we're going to look at what's happening on Beacon Hill, and most importantly, how those of you watching this can use the tools provided here to get involved. And that really is at the crux of this. We need your engagement and your involvement on this issue. So, Matt Valliere, thanks very much for taking time out of your very busy schedule. Could you first tell us a little bit about yourself and also the work that you do at PRAF?
Sure, Myrna, thanks so much for having me. Myrna and I have been working together for kind of a long time at this point. I am a Worcester native, and as she said, am the executive director for the Patients' Rights Action Fund, which is a 501c4 organization based in New York City. We have a sister organization called the Institute for Patients' Rights, which is a 501c3, a more traditional nonprofit, that does more on the educational side of things, PR and litigation. So I have been working on this issue for almost 12 years. It's become something of a life's work for me. I grew up in central Massachusetts. My father and my sister are both in direct care for people with intellectual and developmental disabilities. We saw a number of instances over the course of growing up where people who were supposed to be acting in somebody else's best interest often were not. And those people were vulnerable and put in difficult situations or harmed by the decisions of others. And as Myrna indicated, there's a very broad coalition here in Massachusetts and in other states across the country. People who are left of center, right of center, secular, religious, and in fact, not even in the centers, like pretty far left and pretty far right, you'll see come together and hold hands and agree on this particular issue. It's an odd thing. It does not cut across the usual party and worldview lines. And so the Patients' Rights Action Fund was actually, we were founded in 2013, right after the Massachusetts ballot initiative. If some of you may recall that at that time, some 70% of likely voters in Massachusetts were going to vote yes on assisted suicide. It was on the ballot. And on election day, 51.5% voted no. And this was an election year where President Obama was elected to be the president, and by a significant margin here in Massachusetts. So that's indicative, right? It's indicative of a few things. One is that Odd Bedfellows Coalition was successful by speaking to the whole audience instead of just one side of the aisle or the other. But it was also indicative that our side needed a secular, nonpartisan organization that could help the various stakeholders come together, build trust, work in coalition when they're often opposing each other on other bills at the State House, which is interesting and fun in its own way. But when there are such animosities at times over very hot button issues, that can make it very difficult to work together on the things that people agree on. So having a kind of neutral territory, a sort of clearinghouse, a neutral organization to work together with these folks and then hopefully bring the folks together. So that's been our mission for since 2013. And that has proven a successful model. So as we've seen here in Massachusetts, it continues to work well. Not that we originated anything. It's sometimes just facilitating the coalition to work together and providing resources and organizing events and things like this. That's something that we can provide that other organizations are not necessarily in a position to do. We do that across the country. So any place where there is proposed legislation that has to do with assisted suicide laws, either to legalize in the first place or to expand existing laws, the Patients' Rights Action Fund is there working hand in hand together with local stakeholders, providing resources, strategy, and that neutral ground within which everyone can work together. Our Institute for Patients' Rights, the 501(c)(3), we do a lot of educational efforts, providing resources, doing community presentations, speaking at events. We'll also do a lot of PR work. So our side across the country will typically get nearly as much media as the other side because of those efforts, right? So it's not, we are often a resource to the media when journalists are writing their own pieces, and we've done a lot of outreach and educational work with editorial boards and journalists across the country. It provides an opportunity as well for our side to have editorials into those same papers. So that's some of the work. And then, of course, as some of you know, but Myrna knows well, our Institute for Patients' Rights is collaborating with a handful of the disability rights organizations across the country to sue states that have legalized assisted suicide based on the Americans with Disabilities Act and the Constitution. We believe that assisted suicide laws violate these federal anti-discrimination laws and the Constitution, and thereby should be overturned by the court. We're currently suing the states of California, Colorado, and Delaware, with more to come, and we hope and look to get to the Supreme Court for a total victory on this issue to abolish assisted suicide once and for all. So I think that's a kind of at least a good place to stop and move to the next thing, just as an intro to our work and our organization and our kind of longstanding history with MCFL, but as well as other allies on the issue from across the political spectrum. And I think that that's helpful to understand the issue in general. It's not one of these things where it's falling on one side or the other, or it's the other side might like to characterize it that way, but it's clearly not the case. And I think that the media has at least seen that, and legislators here in Massachusetts have seen that very clearly.
That's great. Before we proceed, can you quickly make a distinction for us between euthanasia and assisted suicide?
Sure. These are particular terms. Assisted suicide, practically speaking, with regard to the law, is such that a patient who has 6 months or less to live, in the subjective opinion of the medical professional currently in front of them, in a legal state can ask that physician to help them to kill themselves. So they themselves do the killing. If the medical professional agrees and says, yes, you have 6 months or less to live, and you meet all the other criteria, at least the letter of the law. Let's just say that, because the law is not always followed as it's written. But then that medical professional, whether a physician, a PA, or maybe an NP, depending on the state, can write a prescription for lethal drugs. That person is going to go down to CVS. The script is filled. They take it home. Once they walk out of the pharmacy, there's zero oversight, and they kill themselves with an overdose of lethal medication that they must according to the statute, self-ingest. That means that somebody else can't do it for them. Self-administrate. It can be administered in other ways than simple ingestion. So that's assisted suicide. The person gets drugs from a pharmacy, a prescription that their doctor wrote, and they go kill themselves. So assisting in their suicide. Whereas euthanasia can be any form of medical killing where the doctor or the other medical professional does the killing themselves, as opposed they kill the patient. Right? So that's different than assisted suicide, as the patient kills themselves. Now the patient could have requested to be killed. And in that sense, there's a way in which they have some agency there. But there are instances, especially in the Netherlands, the reporting from the country itself is very clear that there are both involuntary and non-voluntary euthanasias performed in the Netherlands. And there's a Groningen protocol where they have written out under what circumstances it should be permissible to euthanize children up to the age of 2 if they're highly disabled and the parents suggest that this would be a better thing for the child, then people do this and get away with it, even though this is not quite within the parameters of the law. Right? So euthanasia, assisted suicide, different things. Now, what you'll also hear are the oftentimes, in great part because of our northern neighbors in Canada, they coined the term medical aid in dying. So this is a euphemism for all the above, right? So the umbrella encompasses both assisted suicide and euthanasia. And here in the States, the proponents here used to call assisted suicide, quote unquote, death with dignity, also a euphemism. They've gotten away from that and have adopted the Canadian terminology, medical aid in dying, or simply aid in dying. They've done that because it's just so popular in the media and it's easy. It's an acronym. They use MAID oftentimes. But the proponents here will just cross their heart and hope to die that medical aid in dying only means for people who are actually dying, that they're terminally ill. Except that's not what it means in Canada, where the word came from. So these are all a bit confusing at times, especially when you're not working on it day to day, when this is not kind of your issue. But it's very important to understand those terms and to kind of make distinctions between them, both the terms that we're willing to use and the terms that the other side uses in order to smokescreen people and whitewash the whole thing, right? So this is important in part in the fight, as advocates who are listening here always use the words assisted suicide. So if we're talking about people who are requesting to die, whether they are requesting help in killing themselves or they're requesting somebody else to kill them, there is a way in which that's suicide. And so we have to be mindful that that's the word that should be used because the person is killing themselves. And in fact, the other side came up with the euphemisms specifically because they did polling and research and realized, as did we, that their euphemisms gain them 10 percentage points of acceptance of this public policy. So, and vice versa. If we say the words assisted suicide, I mean, all of a sudden you get a drop off in support, which is what we want, obviously.
That's all very, very helpful. Thank you for clarifying those different terms, and they'll come up again throughout our conversation. So, as we have discussed this issue and as we've educated and advocated in the last several years, I would say the most common response or argument that I hear from others who either aren't sure how they feel about assisted suicide or are openly supportive of assisted suicide, the argument they most commonly make is, shouldn't somebody be able to have a say in how they die? It's their life, after all. Why would we prevent them for making that decision. What what do you counsel us to counsel back to others when we hear that point of view?
So when someone says, why would you prevent them from having this choice? The status quo in Massachusetts, they have the choice. I don't recommend it. I don't advocate for it. I myself have lost a family member to suicide, but there's no state in America that criminalizes suicide. And as is evident from the suicide epidemic, there are no dearth of lethal means in this country. What proponents want is yet another means to the end that they already have. So they already have this at their disposal if they would like it, uh, which would be a tragedy, right? And I'm speaking on my own behalf. I mean, the organization, the Patients' Rights Action Fund, we take no position on the moral or ethical implications of somebody taking their own life. And in fact, there are people who work in our coalitions and in the state of Massachusetts um, who would vehemently advocate for a person's you know unilateral decision to end their own life, right? So this is not the question in the public policy. The question in the public policy is, um, and this is where advocates should always go back to the public policy. We're not talking about whether should be some moral or ethical compunction about you taking your life or me taking my life, or why are you trying to stop me from taking my life? Nobody's stopping you from taking your life. We hope that you don't, right? Like, I hope that you don't. But what we're talking about is a public policy where the state of Massachusetts, the Commonwealth, would be carving out of the manslaughter criminal law the assistance in suicide. And as we learned from the Carter case, like, we don't tolerate that. um, if somebody helps somebody else kill themselves, that's a crime in Massachusetts, punishable with the criminal code. But the proponents would like to carve out of the criminal code that some people should, in some certain circumstances, have no liability, criminal, professional, or civil, when they help somebody kill themselves. And so, what are those circumstances? Nobody is here to, in the advocacy against a very specific bill, to say, like, we're trying to take your agency away. What we would argue, and I think is patently obvious, is that when you legalize assisted suicide, you are putting other people at risk of deadly harm and discrimination. And so, in the balance of all public policies, it's the sort of thing where tough cases make bad law. I'm not suggesting that people in the Commonwealth don't die poorly in some circumstances. They absolutely do. And I've witnessed it myself. I'm a first responder. I mean, like, you see some pretty unfortunate circumstances, but it doesn't have to be that way, first. And second, even if there are tough circumstances, is the response to social ills helping people to kill themselves, having the state pay for it, having medicine participate in it, where they already have the agency to do this thing? Why involve all of these financially motivated players who could, for those who have barriers to access to care, they might be economically disadvantaged. They have less choices, as a matter of fact. They don't have the range of choices, and they're not always empowered to make them. And so, in the imperfect world in which we live, where not everyone has equal access to top of the line care and the range of options and the power to make them all, when you put assisted suicide, which is ever cheap and always easy, on the table, you're putting both subtle and explicit pressure on some people. There are too many dangers associated with legalizing assisted suicide to make it a safe option, even if in some utopia you thought it could work. I'll also say that, not everyone has a nice family, you know, and coercion always happens behind closed doors. So are we really willing to take those risks? So another way that we've often talked about it is that there are going to be what I would just call in a general way collateral damage. So even if you thought that assisted suicide was good in principle on some level, um, there are people for whom you think it would be a tragedy if they used it, right? So who are those people? There are people every year under assisted suicide laws in the United States who die that most people would not consider terminally ill, and that would consider, well, this is a tragedy. There are people with diabetes who are also depressed. They get off their insulin in order to qualify for lethal drugs, not because the diabetes is killing them. They could live for decades. It's because the depression. And they want to escape that pain. And in their minds, what makes their pain any different than the pain that people might experience at the end of life? There are people with eating disorders who are told your case is hopeless. You have quote unquote terminal anorexia, which is a fake diagnosis that was made up by a proponent doctor in order to have legal immunity when she started helping her young women patients kill themselves. You have a copycat suicide in Pennsylvania, where a young woman who had various attempts at suicide and clinical depression and anxiety. She looked up a published cocktail of lethal drugs that was published by proponents, acquired those drugs, and killed herself. Right? You have a young woman in Oregon who impersonated a California physician who was licensed in Washington State, goes over the border, gets the drugs, comes back, and kills herself. She wrote herself a prescription for lethal drugs. There's no safeguards that are gonna be sufficient in the end, and so there are going to be
That's a
ways that
point that we need to keep in mind too, and I'm glad that you're bringing it up because that's one thing that the other side consistently claims is that no, these bills, these laws that we're working to pass include safeguards so that the vulnerable won't be mistreated, and we've included everything, just to really narrow the the kind of person who would qualify for medical aid in dying. And yet what you're saying correctly is that those safeguards can be written in, but there's no way for them to be followed or managed.
yeah, the only perceptible authority in the statute is the health department, and one of the health departments are like, well, we have no funding nor authority to manage problem cases or to investigate. Um, Even in the instance uh, there's a woman who received a dementia diagnosis. She was experiencing no symptoms of dementia yet, but she knew she would get it. She was a ardent proponent, went to one of her proponent doctor friends and said, I'm going to stop eating and drinking, and I want you to qualify me for lethal drugs. That's exactly what he did on day 5 of the fast. On day 8, she's dead from lethal drugs, a perfectly physically healthy human being. So what does that say about how we treat vulnerable people? How are we going to address that in a more meaningful way? I take a look at our own state of Massachusetts, and you know, a lot of people don't even access hospice care. So for many people who are in these circumstances, the majority of people who ask for lethal drugs are on Medicare. They're older adults. And so if you're on Medicare, Medicare will not, pay for assisted suicide because of the Federal Assisted Suicide Funding Restriction Act. It's a little like there's no federal penny that can be used in any way related to assisted suicide. So there's there are people who could qualify for hospice under the Medicare benefit. So hospice would be wholly paid for by Medicare. Many people don't really do this thing. So in Massachusetts, we are not high on the list of hospice utilization. Less than half of residents in Massachusetts utilize hospice at all, and only half of that half are on it for longer than a week, which means that they're not really actually gaining the benefit of what hospice could provide. Now, hospice is often viewed as like, oh, they're just going to come in and kill me, with lethal drugs. Um, I know that there are some bad actors. That is not, by and large, what people are going to experience with hospice. Hospice in general is a good and beautiful, neither hastening nor preventing death mantra. So they're going to come in and alleviate your pain, whether it's physical, psychological, mental, spiritual, even. Like, if you have a faith path, they will go find some spiritual leader from your faith path, and that person is part of the team. And they will even provide the Medicare will provide mental health counseling for your family, even 6 months after you pass. If you can't move around, they'll bring in a medical bed. I mean, like the whole nine, right? So people don't necessarily realize what all the benefit includes. They think they're just going to get shot up with morphine. It's not the case. The morphine can be overused, or too much of it or something, but the family can also needs to be active and be part of the advocacy there. While at the same token, you have to be thoughtful that, oh, well, if we legalize assisted suicide, we're trying to address this dying and pain problem. But here's this other thing that's already on the table, paid for by the federal government for most people, that would alleviate your physical pain in the vast majority of cases. And for the extreme few people for whom the pain management would simply not suffice, I don't take anything away from their suffering. I feel for them. I think it's there's just some things that neither policy nor medicine are equipped to tackle, and that's one of them. Is if you try to do it through helping the person die or killing the person, you bring in its train of this public policy just far too many dangers and the discrimination involved, right? So the reason why I say discrimination and that itself is a danger is because if we say, okay, 6 months or less, 6 months, what does that mean? It means that somebody's got an illness that underlies that prognosis. All those conditions, whether it's diabetes or cancer, whether it's, I've got a high spinal cord injury and I need breathing support. Those things qualify people for lethal drugs. Anorexia, disability under the ADA, right? All these conditions that render a person with a 6 month or less prognosis, all of them are disabilities as defined by the ADA. And if everyone, except for that group of people, get suicide prevention when they express a desire to kill themselves in a medical setting, they're going to get suicide prevention, except this group of people. Those people, they get suicide help, right? Like, that's classic discrimination. You just took a
Right.
protected class and you said, we're going
Hmm.
to treat you in a different way, and it's not better. It results in death to the devalued group. This is both a failing of society and a tragedy. And I think that uh, what most people aren't necessarily viewing it through the lens of is that it's also discrimination and it's against the law. That's why we have, I think, ground to stand on with regard to these lawsuits that we're filing.
Right. Right. And I actually wasn't aware of those lawsuits that you all have filed across the
Okay.
country, and it's outstanding. It's amazing, and I do wish you the best on that because those are the precedents that need to be set to
Mhm.
really make traction with this. When we're looking here, though, in the interim, before you have all those wins, um, what do people need to know about S 1486, which is the current bill before the legislature related to end of life options?
Mhm. So the bill in Massachusetts is a carryover from last year. It had a companion in the House as well. They're identical bills. The big takeaways here, I mean, they're problematic in the same way that all assisted suicide laws are problematic, and we've discussed a lot of that already. But in specific, um, the Massachusetts bill can and will inappropriately make lethal drugs available to patients who are not dying and may even be able to fully recover from their conditions. So I'll just take anorexia as one of them. People um, with anorexia can and will qualify under this bill as they have qualified for lethal drugs and received assistance in their suicides in other states with similar bills. But it's also for things like there are certain treatable cancers that have like 90 or 95% recovery rate. If the person exercises their right as a patient to forego care, then they can automatically qualify for lethal drugs. So that includes those particular kinds of cancer. It includes things like diabetes if they get off their insulin, renal disease if they stop dialysis. Anything that a person requires to keep themselves alive. So I have a friend who, got her thyroid out. If she doesn't take thyroid, she's dead. So she could forego care as a patient, get off of her thyroid medication, and that would automatically qualify for her for lethal drugs, even though she would live for decades, like so many of these other sets of people, subsets of people. They would live their normal lives. My dad's got diabetes. If he gets off his insulin, he could get lethal drugs in Massachusetts were it to be legal here. Um, that that is really concerning, and it should be something that concerns legislators. And I think it's something that folks need to know about this bill is that it can and will um, uh, qualify non-terminal people with life-threatening conditions that are treatable. It will qualify them for lethal drugs, and some people who, in a dark moment, might end up taking them. Now, it doesn't always happen that it's because they forego care. Some people don't have access to care. Some people living in Massachusetts might be underinsured or uninsured, despite the insurance mandate. There are people living in Massachusetts who are undocumented and don't have insurance, and they uh, would be at grave risk under this law. Um, Sometimes when people are provided a set of options, and like one of them's like, you know, I can't get the thing I need to live, so I'm going to be dying in writhing pain, or put my family in terrible debt, or I kill myself. Like kill yourself begins to feel very reasonable, even if you're not excited about it or you think it's wrong to do so, right? Like these things change. The vision changes when you put the new lens of your situation in front of it. It fails completely and utterly to protect vulnerable people from manipulation and abuse. So, um, if somebody has a life-threatening disability, illness, there are people around them um, who, behind closed doors, may gently encourage or out and out threaten and encourage the idea of taking lethal drugs, getting lethal drugs, requesting the lethal drugs under the law. So, um, disability and elder abuse is on the rise in this country. Massachusetts is not immune from that. I've seen it with my own eyes in my own family. Um, when there are tired caregivers and greedy heirs, when under this bill, one of the witnesses to the request can be a beneficiary of your estate. Now, like, just to be clear, I can't make somebody my power of attorney to sign for me when I am incapacitated. So like I have to have a surgery and I'm out for the count for like a week or something. My wife has to make decisions or what have you. Like if it to make somebody else your power of attorney to sign for you in legal matters, this is just your stuff, right? Nobody who's the witness can be a beneficiary. And yet the witnesses for you to kill yourself and be approved for that, um, one of them can be your beneficiary. It's like these
Mm.
are the financially motivated players in this whole scenario are ubiquitous. You've got,
Right.
in the state of California, they legalized assisted suicide under a special session in order, which was called by Governor Brown at the time to come up with $1 billion shortfall in their Medicare program. So imagine if Mass Health had $1 billion shortfall, like assisted suicide would potentially be a nice money saver for the state, right? So like the state stands to save a lot of money in their Medicare and Medicaid program because Medicaid dollars, state appropriated Medicaid dollars can and are used in other states to pay for assisted suicide, even though the federal dollars cannot be used in that way. Um, you've got the for-profit insurance companies who, even if a small percentage of people decide to opt out of care in the last 6 months of their life, they're going to save millions.
Right.
And then you've got, of course, the family members who would stand to gain by an early exit by the person holding the purse, right? So these are scary situations. Now, in some cases, because after the drugs leave the pharmacy, there is no oversight, the Massachusetts bill would leave individuals to die alone, potentially like actually terrified and trying to do trying to accomplish the assisted suicide with no medical supervision, no oversight, nothing. So nobody even knows at the time of ingestion whether or not the person had capacity to make this decision. Nobody knows whether they made it of their own free will or whether some tired caregiver or greedy heir, shoved it all down their throat. Nobody has any idea. Like there's no third party witness involved, and if something goes wrong, there are no medical professionals present to resolve the matter. And so we see various instances come out of the woodwork where the thing has gone wrong. People call 911 or, they're reported as screaming out in pain because the drugs burn their throat. Different cocktails are used. There's no FDA approved cocktail for killing yourself. And so the death doctors will put together their own protocol, and it's all just experimentation on the patients who ask for help in killing themselves. Everybody's saying, "Oh, it's a peaceful pill." It's not one pill, and it's not always peaceful. That's the lie. It's over 100 pills or a liquid that is putrescent, and you got to swallow it. And you're swallowing poison, and so your body doesn't like that. It sometimes reacts against it. And these are the things that they don't tell you in their whitewashed videos of the beautiful people killing themselves on a hillside in California. I mean, like this can be ugly, and I think people have to recognize that. So when somebody expresses a desire to kill themselves in a medical setting, I mean, I don't know about you. Last time I went to the doctor in Massachusetts, they're like, "Do you feel safe at home? Have you thought about hurting yourself?" These are the questions that you're now asked at every juncture in a medical setting. If you were to indicate, "Yes, I've thought about hurting myself," suicide prevention care immediately, right? This is what we do. This is the standard of care. And assisted suicide risks eroding the standard of care and then risks medical professionals now making subjective judgments about whose life is worth saving and who isn't, and what should I do about that? Those kinds of things. And these are real questions. I myself, as a medical professional, you call 911 in my town, I'm going to show up at your house. If you threatened or attempted suicide, you know, are we going to sit there and like ask you, did you get these drugs legally? Like, are we going to try to save the person or not? Like these are really difficult circumstances that you put people under, that it really like skews the standard of care and what the response can and should be. Additionally, for those, so the Massachusetts bill requires medical professional participation, even if on some level, even if medical professionals find this contrary to their ethics, their morals, or their deeply held religious beliefs. Now, what does that mean? It means that a medical professional may need to participate in this on some level, even if they don't want to. How so? Okay, so if you have objections to this, the bill would obligate conscientious objectors to prepare consumer disclosures as prescribed by the Department of Health and forcing them to speak the government's message about assisted suicide. This disclosure profession, the provision threatens both the healthcare provider's freedom of speech and the practice medicine consistent with their ethical convictions. But what it also does on a practical level is it makes it very dangerous for people who don't want to be under the care of someone who might help them kill themselves in a dark moment. You know, if you know that that's a risk for you, you
Hmm.
will opt, I would opt to go to a place where I know they don't participate.
Right.
But if the state is forcing them to give me information about it anyway, and I happen to, have a mental health cold and I'm not feeling very good about myself, and then I might go for it with the information that was forced by the state to be provided to me, even though the medical professional didn't see that as my best medical good. Um, it also prohibits healthcare providers from disciplining an individual for providing lethal prescriptions under the act. So if say there was a hospital that decided to opt out, which in legal states many clinics and hospitals do, both religious and secular. If a medical professional decided to do assisted suicide anyway, in contradiction to the employment agreement, um, under this bill, they the conscientious objecting party might not have any authority to do anything about that. So that
Mhm.
puts the patients that they were there to protect at risk. And it gives the patients less options, right? So if there's no place you can go where you're certain people aren't going to help you kill yourself, now you don't have options either. And so because of, in the name of choice, supposedly they're taking choice away. So take a choice away from both these medical professionals and the people who would like to receive care from a place where that's going to happen. So that's kind of a very rough outline of some of the biggies that are in the Massachusetts bill. Um, I would say that in general, though, yeah, it's a lot like the other assisted suicide laws, and it presents a lot of the same
Right.
same
Right.
issues.
I mean, that's what they're known to do, right? They sort of take what worked in Oregon or Washington or wherever and apply it here, hoping it'll work here as well. One other question while we're kind of talking about the details. Um, Hypothetically, and perhaps this depends on an individual's life insurance policy or stipulations, but in your experience, have you seen life insurance companies um, pay out after somebody has committed assisted suicide?
Yes. So the reason being is that nowadays most life insurance policies will cover after 2 years. So if you're 2 years past the origination of your policy, they'll cover even if you did kill yourself by suicide. Um, but even if you're within the 2 years, um, because this bill in Massachusetts and all the statutes that have passed like unilaterally claim that this is not suicide, this cannot and should not be construed in the law in any way as suicide. Uh, they basically redefined what suicide is and means and hamstrung the life insurance companies to pay out because this is not suicide. This person, the disease killed themselves. The disease killed the person,
Right.
not the person killing themselves. So, and in fact, in most
Mhm.
states, and I would have to look more carefully at this bill to be 100% sure, but most states require that even on the death certificate that the medical
Right.
professional lie and
Yes.
say that the person died of cancer or whatever it was, anorexia, and yet they died from an overdose of lethal drugs, which normally you would, as a medical professional, you would write what the person actually died of on the death certificate.
Hmm.
But instead, all
Right.
of these vital records are being falsified by statute, And so all the numbers are off, and information is being withheld from people who stand to gain or lose, including the life insurance companies.
Right. The whole thing is just packed with subterfuge and very gray areas, intentionally gray, um, which is how you know that it's not ethically concocted in any way, shape, or form. But
Yeah, if you really
so
wanted transparency, you would like make it transparent, right? You would have third
correct,
party
correct,
reporting. You would have like accurate everything. You would have third party witnesses. You would have,
right.
but there's no ombudsman for assisted suicide. It doesn't exist. There's no oversight after the drugs leave the pharmacy. All of it's written very vaguely, and it's all
Mm-hmm.
anything that's not
Mm-hmm.
is protected by HIPAA. So it all happens behind a shroud,
Right.
and it's purposefully opaque in that way
Correct.
so that the dangers and the risks and the problems never surface. When
Mm-hmm.
they do surface, it's rare, right? With with other states, we've the states that have passed assisted suicide, we've made Information Act requests.
Mm.
They don't give you anything. Like the level of like hiding what's
Yes.
going on, very high.
So before this all happens here, and I guess two quick
Hopefully it won't,
questions.
Myrna. We got to keep winning.
Hopefully it won't because we're on it. What do we need to do more of? We've been successful to date at holding this thing back. But as I said, the culture is moving to accept it more rapidly and readily than they used to. So what can viewers do to help prevent this from being legalized in Massachusetts?
So a couple of things. I think one is that firstly, I do think people are still pretty split on this. And in fact, uh, support for both euthanasia and assisted suicide in the latest Gallup poll is down. So it's not on the rise and steadily rising. It's been up and down, and on first blush, you know, acceptance of just whatever it is, just over 62% or something, like up and down from there. But give that as the average. And when people learn the implications of the law, that support goes down, which is exactly what we saw here in Massachusetts. 70% of likely voters on first blush in 2012 saying what they would vote yes, and 51.5% voting no. That's a huge swing. So how did that swing happen? The swing happened because people learned about the law. They didn't know what the implications were. And I think right, left, or indifferent, old, young, baby boomer,
Hmm.
millennial, doesn't really matter when people actually understand who's at risk and that it's a risky public policy. They're a lot less likely to support it. So
Hmm.
I think that talking about this issue with your friends and
Right.
neighbors is good and helpful. I think that you want to, say there's a local paper and you want to write in um, an editorial, letter to the editor, what have you. I would ask that, any folks would talk to us and work with us as they think through how they message that. But at the same token, like getting the word out there that here's the dangers. And you can go on our website. I'm sure you have resources too at Mass Citizens of like, here are the implications of the law. Ding, ding, dong. And it doesn't matter what worldview somebody's coming from. Everyone thinks those things are problematic, right? So
Right.
um, if we get those dangers and concerns elevated and you use real people's stories
Right.
that we've published on our website, others have as well, you can take those, and I'm not just saying like we publish it and it's on our authority. I mean, like I'm talking like the Atlantic, they recently published a major splash um, victim of assisted suicide story. I'm like, use her story. Not it's
Hmm.
a tragedy, and I'm not saying that we shouldn't feel for that tragedy and just simply use it as a political tool, but people need to know that that could be
Right.
their daughter next, right?
Right.
Is it going to be their daughter next? Um, is their daughter who's 18 and happens to be struggling with an eating disorder, And the doctor says, yeah, look, like your case is hopeless. Like if you want to die, I can help you do that. Do you want that? Does anybody want that in Massachusetts? I hope not, right? And I hope that that's enough. I, I was I knew and was friends with a young woman that she received lethal drugs in Colorado for anorexia. She didn't end up dying of that, thankfully, because her parents intervened and received guardianship from the state. Her dad did, and then he had the drugs destroyed. She ended up getting better. Surprise, surprise, right? Like she did pass away ultimately from complications to her health from the eating from 20 years of starving herself, right? But
Right,
um, that's a story you can use. It's published right in the Denver
right,
Post, right? The
right.
Denver Post, that when they were like, "Hey, are you sure about this?" I was like, "Yeah, I can produce the medical records. I could, you could talk to her parents if you want to, whatever." And so they were like, "Okay, we'll do it. We'll publish this."
Wow,
So
that's fantastic.
this is the
So
kind of thing
powerful.
people need to hear this, right? People need to know,
Yes.
and
Yeah.
if they're going to vote yes anyway, um, I can it's hard to comprehend that, but it is true and it does happen. People will vote yes anyway in the face of those things, but a lot of people change their minds. And so I think
Right.
you need to help change people's minds, oh viewers, through these stories, through these dangers, through
Hmm.
elevating the implications of the law. And I think that you don't need to go in trying to, convert somebody to your side so much as give them second thoughts about whether or not this is good public policy. And that typically will be enough for a
Right.
no or an abstention in the state house. But it could also come back to the ballot box, and
Mm.
that means talking to your friends and neighbors.
That's right. That's a whole different education campaign that would happen at that point. Now,
Mhm.
before we conclude, Matt, is there, knowing the makeup on Beacon Hill as it stands right now, knowing, which representatives and senators are leaning this way or that, what, any last piece of advice for us as we consider lobbying our elected officials?
Um, I think a few things that it never hurts for your elected officials to hear from you. And I know that both you and we certainly have a landing page that makes it very easy for you to contact your legislator via email. You can also make a phone call, and even if you don't end up actually able to talk to your legislator, um, their staff people do take the notes down, and they understand that there have been a certain number of people who called them asking them to vote no, and that's important. Some legislators are really kind of on the fence, and they'll just or they're uncomfortable with the idea, but they're getting a lot of calls from the other side. If they have a handful of calls from our side, it's enough for them to be like, yeah, I'm kind of uncomfortable with this, and I don't really want to, that kind of sentiment. They might not be a hard no, like you or I might be, but they're just ill at ease. And that's the feeling that we want to continue. We want them to continue to feel ill at ease with this, um, and continue to understand uh, that these laws present risks to vulnerable people. And the more of that you do, the more of that you help them to see and understand, the better for Beacon Hill. Whether your legislator is, Republican or Democrat, doesn't actually matter. It's like there are some Republicans who support this and some Democrats, like lots of Democrats who oppose it, which is why it hasn't passed. So
That's right.
encouraging those Democrats to continue opposing it is important. They sometimes do that in different ways. And sometimes it's quietly, and um,
Mm.
the way that Beacon Hill sometimes works is not so, pound your chest, rah rah, go us. It's a little more subtle than that, and giving them the courage of constituent support, I think, is key.
That's perfect. Matt Vallière, thank you so much for providing so much insight, and thank you for the work that you do at Patients' Rights Action Fund. If anyone wants to find out more information about assisted suicide here in Massachusetts, you can send an email to contact@masscitizensforlife.org. And then, Matt, what's the best way to contact PRAF if folks want your insight?
Sure, if you just go to our website, that's PRAF.org. So PaulRalphAdamFrank.org. If you're looking for resources, there's a resources tab. There's a lot of helpful information there. And then if you would like to stay informed, if you go to the About tab on the toolbar, push Stay Informed, and we'll bring you to a form to fill out. We will keep you advised, both what's going on nationally, but also across the country, and ways that you can plug in and help out.
Great. And if anyone has questions for Mass Citizens for Life, you can write to us at action@masscitizensforlife.org. So Matt, thanks very much again. We were
Thank you,
really
Myrna.
grateful that you were joining us today, and I wish you all the best. Thanks for your help.
Thank you. Take care.
Bye-bye.